Hi, I'm Dr. Tom Schneider. I am a pulmonary and critical care specialist, and this video is about ventilator use for COVID-19 patients. The reason for this video is that many of the patients have had poor survival when placed on ventilators. And so I want to talk about ventilator use in these patients when they develop acute respiratory distress syndrome, otherwise known as ARDS. There was a landmark study published in the New England Journal of Medicine in May of 2000. It showed a 22% drop in mortality if certain ventilator settings and approach was used in the ventilation of patients with ARDS. I studied this closely and took a number of courses in regard to it because the journal article itself was hard to decipher in terms of the exact protocol they followed. Over the years, I've treated many patients with ARDS, and many of them would die, as there was only about a 40% survival back then. And many of the patients would languish on ventilators for 6 weeks to 3 months or even longer. When I learned the material based on the landmark study in the New England Journal in May of 2000, which is about reducing tidal volumes, my results in treating patients totally shifted. I had a total of 10 patients on whom I used the protocol faithfully and also added certain medications to that in the management of patients with ARDS and respiratory failure. The result was that all 10 of those patients not only survived, but got off of the ventilator within 2 weeks. This was shocking to me because my prior experience with the management of ARDS had been like every other pulmonologist, where again the survival was only 40 to 50%. So when it turned out that all 10 of these patients on whom I applied a particular strategy all survived and got off the ventilator within 2 weeks, that was really an astonishing result to me. Many of the patients with COVID-19 do die of ARDS, and that's why I think it is relevant to discuss this at this time. And I want to offer instruction to fellow medical professionals in regard to a winning strategy for the management of ARDS. I would like to start out discussing the importance of the plateau pressure. Many of you know about the plateau pressure, but I will review it anyway. Most often in ICUs nowadays, we're monitoring the peak inspiratory pressures, but the peak inspiratory pressure isn't what we need to monitor in ARDS. We need to monitor the plateau pressure. That's what gives us the critical information in knowing how the patient is doing and knowing how to adjust the ventilator. So I have a diagram here, and this is a pressure time curve with pressure on the y-axis measured in centimeters water and time on the x-axis measured in seconds. This is representative of a breath from the ventilator, one breath, with the ventilator being in volume control or assist control. This is inhalation, where the ventilator is delivering a breath to the patient until it stops delivering air, and this is the peak pressure, or the peak inspiratory pressure. This is where the ventilator stops pushing in air, and if you continue with a normal breath, the dashed line shows expiration, where the ventilator allows the air to escape and the patient passively expires. If you deliver ventilator breath at peak inspiratory pressure, you then apply an inspiratory hold or an inspiratory pause. This will yield the plateau pressure, which is an end inspiratory alveolar pressure, so that you're seeing what's actually going on with the alveoli of the lung. Since this is delivered at a certain volume and it yields a certain pressure, what you're looking at is also compliance of the lung. You're looking at how over-distended or stiff the lungs are, and that's the information you get from the plateau pressure. You cannot get that information from the peak inspiratory pressure, which includes the pressure from the compliance of the lung, but also includes pressure from resistance. So to isolate out what's going on with the stiffness of the lungs, you need to measure the plateau pressure. We should not be adjusting the ventilator based on the peak inspiratory pressure. So I consider the plateau pressure all important. And in addition to measuring oxygenation and ventilation with the PCO2 and the pH, it's the plateau pressure that really lets us know what the lungs are doing. So I consider it a critical pressure. Unfortunately, in most ICUs, it's not really something that gets people's attention or that's looked at in a systematic way. So I would encourage the initial ventilator settings to include a volume control setting, such as assist control, AC, because pressure control makes it more difficult to monitor the plateau pressure, and you may have to use the peak inspiratory pressure for your plateau pressure. Volume control is much easier to set up and manage the plateau pressure. I also would not use any sort of adaptive pressure control, such as PRVC on the Servo, or VC Plus on the Puritan Bennett, or Autoflow on the Hamilton. These will just confuse matters, as these are modes that are a combination of pressure control and volume control. I know that these modes are popular and what most hospitals use and what most therapists like to use. But those methods of ventilating patients are as much about marketing as they are about physiology. All of the excellent results I got in ARDS management are based on volume control settings, and the whole ARDS network trial was also done based on volume control settings. So if someone wants to do an ARDS trial with PRVC or VC Plus or Autoflow, that's fine, but they need to figure out how best to do this, as the current method I'm describing to you, which has proven positive results, cannot be done adequately with those settings. Period. So I encourage you to place the patient in assist control settings on whatever ventilator you're on. And then going from there, you'll need to set up a tidal volume. The tidal volume is based on the patient's height, and you will need to know the patient's height ahead of time to calculate the tidal volume. So I recommend that you find out the patient's height, preferably on admission from the patient, but if that's not possible, either later on or if that's not an option, check the patient's driver's license that often lists the height, talk to the family who probably will know the height, or the very least of the options is to guesstimate. It is really crucial that you use ideal body weight formulas to calculate the appropriate tidal volumes that you're going to set. This is much better than just guessing at it. So a 350 ml tidal volume for a 5'4" male may be just fine, but the same 350 ml tidal volume for a 5 foot tall woman is excessive. So pulmonologists and everybody in critical care would be well advised to use the ideal body weight formulas to calculate the appropriate tidal volumes. The formulas are really simple. Males, the ideal body weight in kilogram equals 50 plus 2.3 times height in inches minus 60. For females, the ideal body weight in kilograms is 45.5 plus 2.3 times the height in inches minus 60. Once you've calculated the ideal body weight, you then can use that calculation of the patient's ideal body weight in kilograms to calculate all of the tidal volumes. As per the ARDS network trial, set the initial tidal volume at 8 mLs per kilogram ideal body weight. A short while later is reduced to 7 mLs per kilogram ideal body weight, followed by a reduction to 6 mLs per kilogram ideal body weight. This reduction in the tidal volume to 6 mLs per kilogram ideal body weight should be carried out within the first 4 hours after intubation. If the plateau pressure is greater than 30 centimeters water, while the patient is on 6 mLs per kilogram ideal body weight tidal volume, reduce the tidal volume to 5 mLs per kilogram ideal body weight. If the plateau pressure remains greater than 30 centimeters water on this, the tidal volume is then reduced to 4 mLs per kilogram ideal body weight. Of course, you will monitor ABGs and pulse oximetry throughout this time period. Know that some researchers have even used lower tidal volumes than this with good results and no complications. So again, the plateau pressure becomes critical, and I would like to make a couple other comments about the plateau pressure. Very often it's difficult to measure because the patient is spontaneously breathing. So paralysis early during the course of ARDS can be very helpful in getting an accurate plateau pressure, or intermittent use of succinylcholine as a short-acting paralytic could also be used to obtain an accurate plateau pressure. In any case, if the patient is generating respiratory effort, you're not really going to get an accurate plateau pressure. So they need to be passively ventilated when you check plateau pressure. Now, a comment on respiratory rate. Since the tidal volumes will be lower, you will need a higher respiratory rate to achieve a certain minute ventilation. So starting off with a higher respiratory rate is advisable given the lower tidal volumes that you'll be using. And it's not unusual to need a respiratory rate of, say, 28 to 32. And there have been times when I've occasionally used respiratory rates of 35 to 40. The important thing to remember is about permissive hypercapnia, and that is allowing the PCO2 to rise and the pH to fall. The increased PCO2 is partially offset by the increased respiratory rate. In the ARDS network trial, the pH was allowed to drop to 7.15 with no adverse effects. And I've done this multiple times myself, and I have not seen any problems. It is important that you inform your respiratory therapists and your ICU nurses what you're doing, because we're mostly used to normal ABGs. Keep in mind that in the ARDS network trial, the more normal the arterial blood gas, the higher the mortality. Again, the more normal the arterial blood gas, the higher the mortality. What this means is they had to let the PCO2 rise and the pH drop in most of the patients in order to reduce ventilator-induced lung injury and reduce mortality. In terms of oxygenation, I have just a couple of comments. One is that you may have to accept PO2s in the mid-50s or a little lower, and you may have to accept oxygen saturations in the mid to upper 80s. Higher levels of PEEP are often well tolerated with no barotrauma, as long as you've really reduced the tidal volumes. Something else I'd like to comment on, besides the ventilator settings, is the use of non-invasive ventilation. I think that if you are confident that the patient is actually in ARDS and not hypoxemic for another reason, such as a patient with COPD with exacerbation and pneumonia and secretion problems causing hypoxemia, but rather that the patient actually has ARDS as the cause of the acute hypoxemic respiratory failure, then I would strongly recommend that you not use BiPAP on a regular basis. I have worked at multiple hospitals where I've seen BiPAP initiated on ARDS patients in an effort to avoid intubation. These patients that I saw were on BiPAP for at least 2 weeks and realized that the tidal volumes while on BiPAP were often 600 or more mLs. And as you know, it's not easy to control BiPAP-related tidal volumes. But all of them subsequently ended up intubated and had refractory respiratory failure and died. I believe this is due to BiPAP-induced lung injury, similar to what you can get from large tidal volumes on ventilators. This is something that I've definitely seen a few times, and it's not really been discussed much in the medical literature, but I think it's a real phenomenon. So I strongly encourage you not to maintain patients on BiPAP for any significant period of time if they truly are in ARDS. They need to be intubated and treated with this protocol. The other thing I'd like to comment on is the use of medications in ARDS. Steroid use has always waxed and waned over the years, and I have seen a couple of patients with very severe hypercapnia who seem to respond dramatically to the use of steroids. But my personal bias is I do not routinely use steroids in ARDS patients. I admit that's a bias, and there are going to be others who disagree with that. There are a lot of potential side effects, and even so, a decision can be made on an individual basis whether or not the patient should be placed on corticosteroids. I'd like to comment also on neuromuscular blocking agents. They, years ago, were viewed as salvage maneuvers for people in really severe ARDS, but there's literature that they are beneficial early in the course of ARDS. I found this to be true in my patients. I have found that they're ideal for helping to obtain an accurate measure of plateau pressure. They improve hypoxemia. They improve ventilator patient synchrony. And there's a decreased incidence of barotrauma as well. So I think they're helpful in the first few days, but not everybody needs them. Some people with less severe ARDS do not need them. And in those patients, plateau pressure can be checked by intermittently looking at the plateau pressure while the patient has received succinylcholine or other short-acting paralytic. The one caveat I would say about the use of neuromuscular blockers in ARDS is to really try not to use them more than 48 to 72 hours, because they can cause long-term and profound weakness, especially when given in conjunction with steroids. The other thing I'd like to comment on medication during ARDS is I have really found the administration of diuretics to be very helpful. I have seen where volumes of fluid, liters of fluid, have been removed by diuretic therapy, and at the same time, dramatic improvement in the patient's pulmonary status, gas exchange, and plateau pressure. So I really think that the administration of diuretic therapy is very useful. And in my patients, none of them had any sign of cardiac dysfunction on echocardiogram or any other measure. And yet they all responded nicely to the administration of diuretic therapy. Of course, you have to individualize this, because if hypotension is a problem, that may not be a great option. It should be noted in one of my references that there was a study looking at diuretic therapy and the possibility of precipitating acute renal failure. And the group that was given diuretic therapy had actually slightly less renal failure than the group with a conservative fluid management strategy, although it did not reach statistical significance. Prone positioning and ECMO are, of course, salvage maneuvers that can also be considered. I did put together a sheet that gives a quick reference guide to the management of ARDS for these patients. And this sheet could be used separately to summarize the approach. So I think it's really important that we use an optimal strategy for managing the COVID-19 patients in ARDS that I've outlined. I think this really can make a difference in survival and in the length of time on the ventilator. I am making myself available with my website, askalungdoc.com, and that's also found on my other website, healingbreathinstitute.com. Conference calls could also be arranged if a number of people want to talk at once about the strategy. I can be reached through the office number 904-588-2884. Thank you very much for your attention, and good luck managing these patients.